Never in my life I thought that I would be diagnosed with prostate cancer.
The prostate is an organ that helps to make some of the liquid part and nutrition part of sperm.
It's a very treatable disease, so yes.
Welcome! I'm Glenda Umaña, and today we are discussing a health issue that affects men around the world prostate cancer. And right now, it's a lot of awareness since the case of former US President Joe Biden. So, here with us is Dr. and she's a medical oncologist from Emory Hospital in Atlanta, Dr. Jacqueline Brown. Welcome, Dr. Brown.
Thank you so much for having me, Glenda.
And of course, we're not discussing here specifics about former President Mr. Biden's case, but this is an excellent moment to have awareness, to tell people what are the different scenarios, and of course, for men to do that test that is not very nice to do, but is very important. Dr. Brown, let's start with Jeff Oliver, who's going to, get together here with us. I appreciate Jeff Oliver is going to tell us how was he diagnosed. Let's listen.
Well, I learned by, of course, being tested every year for my PSA and watching the numbers fluctuate. They didn't fluctuate much, but then all of a sudden I had a spike and then the numbers came down. So by working with the urologist that I was seeing at the time, we were trying to go through the process of what I needed to do to go through each stage and do it correctly and get the right choice for me. That is correct. Never in my life I thought that I would be diagnosed with prostate cancer, but like anything in life, you deal with what the cards have been dealt. So, yep, I was, and at that point became very proactive as far as looking for the best treatment and results for myself, not depending on what the doctors told me. Well, it's a process that's very interesting, especially after going through it, because what you hear and what you're told are two different things. And I was a shop owner for 20 years, and hearing men come in with prostate cancer and not really understand what a Gleason score is or your options is quite frightful for anyone, especially me, because I was going through it.
Thank you, Jeff, for sharing with us your story. We'll go back with you to learn more what you decided, which treatment you decided for. But Dr. Brown, let's start explaining what exactly is prostate cancer.
Right. So, um, let's start with just talking about what the prostate is, right? The prostate is an organ that helps to make some of the liquid part and nutrition part of sperm. And so this is an organ that sits right beneath the bladder, and the urethra, which is the tube that connects the bladder to the outside world, goes through the prostate. And so it is a totally normal organ in the body. Unfortunately, it's an organ that cells can start to, over time, learn how to grow unchecked, learn how to grow despite the body telling those cells not to grow, and that's the root cause of cancer.
Dr. Brown, the guidelines sometimes are a little confusing, and it depends, of course, on the case, on the age. But right now, for example, supposedly men after 70, they don't need the test, the PSA test. But not everybody agrees with that.
Yeah, it's a complicated issue, so let's unpack this. The current guidelines recommend, as you referenced, Glenda, that men up to the age of 69 consider PSA testing or prostate cancer screening with their doctor. So even for the men who are under 70, it's not a hard recommendation. It's not, you must do this. It's, please have a discussion with your doctor about if this is right for you. So when men get to 70, the recommendation is not to do it. And your listeners may be thinking, why on earth, if this is a cancer that I can get, would it not be a hard recommendation for my entire life? It's a complicated issue, but I'm going to try to break it down. The concern is that, one, there are other things that can elevate a PSA other than prostate cancer. And let's talk briefly about what PSA is. So PSA is prostate-specific antigen, and this is a marker that you can test in the blood. So think of it like a non-invasive blood test that can generally test for prostate cancer if it is very elevated. A normal PSA for the screening test is under 4. We can do this test, and if you have a PSA of 5, does that mean you have cancer? No, it does not. If you have a PSA of 7, does that mean you have cancer? Not necessarily. We know that the higher the PSA is, the more likely you are to have cancer. If someone has a PSA of 100, I am definitely more worried that they have cancer. The issue is that things other than prostate cancer can elevate a PSA. Recent sexual activity can elevate a PSA. If certain infections or inflammation of the prostate can elevate a PSA, which is why, let's say, someone had a PSA tested, then it was 6, that led to a biopsy. A biopsy is a safe procedure, but it's an invasive procedure, and there can be pain associated with it. There can be a small risk of infection and bleeding. And so anytime we put our patients through something like that, we're thinking, does this make sense, and is that risk worth it? So let's say this patient who had a mildly elevated PSA undergoes this procedure. There's now 2 pathways, right? Maybe that biopsy shows no cancer and he went through an unnecessary procedure. Or perhaps the biopsy shows cancer, but maybe it's a really low-grade cancer that isn't likely to spread anywhere, and per our current recommendations, wouldn't need to be treated. And in fact, for certain low-grade, non-aggressive cancers, urologists and oncologists will encourage a patient to not undergo active treatment at that time. So now, not only have we put this patient through a biopsy, but we have now put a tremendous amount of psychological stress because he now has something we call cancer, and all of his doctors are telling him, don't do anything about it. So that's a very confusing pathway for that patient. So when screening guidelines are made, they are trying to advocate for the general population, right? If we did PSAs on every person for all time, and we know that PSAs get higher as men get older, we would be doing a lot of biopsies and diagnosing a lot of low-grade prostate cancer that may never be an issue for that patient. And so is that risk worth it?
So the balance is more on that side, yeah, to do less.
Yes. And that's the reason for that sort of have a discussion with your doctor before 70. Now, if someone comes to their primary care physician and says, my father had prostate cancer, my grandfather, yep, family history is key. If everyone in your family has had prostate cancer in advanced forms, then I would tell that patient it is important that we check a PSA for you, right? And particularly Black men, I think there is data that they have prostate cancer at younger ages, that they have prostate cancer in more aggressive forms. So that may be a factor that would encourage that man's doctor to say, I do recommend a PSA for you, but that's why it involves that individual conversation. And that's why the recommendations after 70 say we don't recommend doing this on all comers because we're trying to avoid unnecessary medical intervention and stress. The problem is there will be people who develop prostate cancer after age 70. Guidelines are for a population.
Family history, right? It's very important. Like Joe Biden, right? In his case, aggressive, aggressive. But it's very low. This rate is very. I understand, and after seeing, I mean, family people, friends that have had, that were treated for prostate cancer 28 years ago, or other different cases there, but the is very high. The survival rate is really more than 90%, right?
So, everything about survival and risk of death from prostate cancer depends on sort of the aggressiveness of that individual prostate cancer. There's a few factors, and I think Jeff referenced a few of these in his own case, that we think about that helps us to stratify an individual patient's risk. We are thinking about the PSA. If a PSA is 5, then we consider that generally lower risk than a PSA that is 100. We think about the Gleason score. So a lot of people, I think, are hearing about Gleason score and wondering what Gleason score is. A Gleason score is a pathological system where when a prostate biopsy is taken and a pathologist, a type of doctor that looks at pathology under a microscope and makes diagnoses, looks at that specimen under a microscope, that number that is assigned tells us how aggressive those cells look under a microscope. So, for example, a Gleason 5 is the most aggressive. That is how those cells under a microscope look very disorganized. They've been growing so fast and so aggressively, they're climbing on top of each other, and you can barely tell that it was prostate to begin with. Versus a lower Gleason score, perhaps, yes, it's still cancer, but you can make out the original glandular structure of the prostate and it's lower grade. You get two numbers with a Gleason score. So as you hear about someone having a Gleason 5+4 or a Gleason 3+4, the first number is the most prevalent pattern and the second number is the second most prevalent pattern. And so that sort of is trying to give us a sense of what we saw in those 12 to 14 specimens from the biopsy.
Thank you for that important explanation. Now, let's talk about the different treatments. Mostly, almost everybody that got prostate cancer, they said we need surgery, but let's listen to Jeff Oliver. First, it was confusing, but he's made his homework, he made his research. Let's listen to Jeff.
The most important thing is to know your Gleason score. So I had a 3-4, which put me in the low to moderate range, which made me a good candidate for treatment. Now, the urologist I was seeing, he gave me no choice. The only choice he gave was just total removal, which at that point I said, that's not a choice. I invest, yes, and you have to be your own advocate. So I just kind of looked at him totally puzzled at this, time and age that there was no other choice. And that was the only choice he gave me. And it's very interesting in running the facility I did, there was a lot of men that came in there that's the only choice they were given. And shame on the medical profession for doing that. So I asked him, I said, aren't there other choices? And he says, well, they are. And then I took a big deep breath saying, well, I really don't want to go through that type of procedure if it's not necessary. Then the radio oncologist came in, did the same thing, examined me, and of course, two different opinions. He looked at me and he said, Mr. Oliver, if you were my brother, I would tell you to do what's called HDR, which is high dose radiation. It's two treatments and your numbers are very good for this, and the outcome would be actually the same if it was removal. And both doctors agreed to that. So I agreed to do HDR. It's well, it's a pretty tough procedure, but you have to weigh out the benefits. So it's done within 2 weeks. It's a matter of they, insert 16 to 18 needles. They take you once they insert the needles, not to get too much too graphic, but the thing about it is once they run the radiation is removed, so you're not radioactive like seeds or anything else like this. And basically, the procedure, what it does, it disrupts the cancer cells, which essentially it terminates the cancer because then they just can't reproduce.
Thank you so much, Jeff, for sharing your story with us. And wow, doctor, I don't know if all the cases are like Jeff, that he was like he didn't accepted He didn't accept the surgery when he was told that he needed a surgery, and he decided to this treatment HDR. Although the side effects are worse, right?
Not necessarily, actually. Not necessarily. I think that's definitely a commonly held belief, but there are side effects to radiation as well, and they can be different. And also, radiation will often require that a patient shows up day in and day out, Monday through Friday, for weeks on end to get that treatment, and that doesn't fit everybody's schedule or family structure or those things. So those are some of the things that go into that decision, as well as sort of rates of urinary issues after, rates of sexual dysfunction after, risk of irritation of other organs from radiation. So lots of things to think about. I do my best to guide patients, but ultimately
I guess it's not easy to you know tell the patient what exactly to do.
Yeah, I think again, and I like to say most of these patients, I see advanced prostate cancer, and we can talk about what that might look like and who my patients are and how I treat them. Um, but patients are uncomfortable sometimes with choice. I think choice is a wonderful thing, and we as doctors want to empower them with all of the options. Some of my patients say, can't you just help me? Can't you just, which one would you do? Which one would you do for your dad or recommend to your dad? Um, and I try to be as honest as possible, but I say, depending on your cancer, both may be equally advisable. Which one fits you, right? If a side effect happened to you that doesn't happen to most people, which ones could you live with? So it is really hard, and sometimes there's a discomfort in having multiple options.
Dr. Brown, so what are the latest treatments for advanced prostate cancer? You as an oncologist, what are you doing now?
So let's say, and I just want to kind of lay out who that person is, who that patient might be if they're coming to my office. And everyone is different, but I'll kind of give an example patient. So let's say a patient comes to my office and they have a PSA that was recently found to be 75. They got a scan with their urologist that showed evidence of prostate cancer in the prostate, in the lymph nodes, and in the bone, in different parts of the bone. That patient will be referred to me. The backbone of how we treat that patient is hormonal therapies. So, hormonal therapies, medicines that reduce the testosterone. Testosterone feeds prostate cancer and tells it to grow. So, we are essentially trying to starve the cancer of its favorite food. So, we lower the testosterone. That's sort of step one. Step two is we add additional oral medicines to treat that patient that further block the hormones that feed the cancer. Those two steps are essential. There is a minority of patients that also warrant consideration of chemotherapy at the time of diagnosis. Not everyone needs that, and that's a discussion with the individual patient and doctor. There are a lot of new treatments in prostate cancer.
Oh, it's very popular now because of Biden's case. That's
Yes, very good news, and it's a very exciting time. Um, the average person with advanced prostate cancer, and let me back it up. I think this has come up in recent, discussions that when prostate cancer has spread outside the prostate, I don't expect to be able to cure that cancer. I tell my patients that we can control it and we can control it very well. My goal is that that PSA goes from 75 to 0. That is entirely possible with therapy. And I watch that PSA over time to tell me how the cancer is responding. Inevitably, at some point, on the best treatments that we just described, the PSA will start to rise again despite us doing what we've done the whole time. Once that happens, and usually that's 2-ish, 3 years later, that tells us that the prostate cancer has learned how to outsmart our treatments, and we need to use new treatments to try to kill it. And that's where the novel therapies come into the picture.
hmm. Are there a lot of cases of men? Because I know some cases, and they wanted us to ask you some cases that they have that they had surgery and then the PSA is high. And so, what is the best treatment in those cases?
Yep, it's our hope for a patient who's undergoing surgery or radiation as their first treatment for localized prostate cancer is that they're cured, but not everyone is cured. So let's say a patient, just like you said, has a prostatectomy, undergoes surgery, their PSA goes to zero, their urologist is watching their PSA, and at some point it starts to appear again, where we see a PSA creeping up. Well, because they should not have prostate tissue in their body, the appearance of that PSA worries me that there is residual cancer cells in their body. So at that point, when the PSA has consistently risen, we need to go looking for what's making that. And so at that time, we will perform something called a PET scan to look and see if there is something visible on the scan that is making that PSA. Sometimes we're able to find something, and sometimes we're not. Sometimes that scan comes back negative, meaning we don't see anything making that PSA. However, if the PSA still continues to rise, that tells us that there's microscopic cancer somewhere that is below the level of detection of our best tools. And so that type of cancer still needs management and treatment.
Like what kind in that case?
So this is a little bit complex, but let's say that that patient had a prostatectomy, their PSA rises, and we don't see any evidence of cancer on a scan. Typically, they will be referred to radiation oncology, consideration of salvage radiation therapy to the bed of the prostate, which is the area where the prostate was removed from,
Radiation is the best. Okay.
in addition to the lymph nodes in the pelvis. Other times, and I'll describe a different type of patient, perhaps that PSA rises and that scan actually shows us that there are multiple lymph nodes involved that are residual in their body that have the cancer in them. In that case, those patients may be referred to radiation oncology, but they'll also be referred to me for consideration of concurrent hormonal therapy as well to treat that cancer.
Okay, doctor, your explanation is so good. I can't. Uh, we are so grateful to have you here. Is there anything else you would like to add? Any information that say, "Oh, I need to tell this to the people, to the audience"?
So there's two sort of important things, and I'm going to talk about patients on either end of the spectrum. We referenced this earlier, but a fair number of men will be diagnosed with prostate cancer, and perhaps they have a Gleason 3+3, or a Gleason, we call that a Gleason 6 prostate cancer. This is a very low-grade prostate cancer, and when that man meets with his urologist and radiation oncologist, our recommendations for best care of that patient is that we do not pursue radiation or surgery at that time, because we are worried that this cancer may not cause any problem for that patient, and so we want to watch it. When I say watch it, that doesn't mean do nothing. That means repeat biopsies, sometimes yearly. That means repeat imaging, sometimes yearly. That means watch the PSA, so it's an involved process for the patient. But the idea is that we are trying to spare that patient morbidity from interventions for a prostate cancer that may not need to be treated at that time. So that can sometimes be very anxiety inducing to patients because they say, I have a cancer, get it out of me, but that's a special facet of prostate cancer that they'll hear more about from their doctor if they fall into that situation. The other side of that spectrum is I see a lot of men with a new diagnosis of metastatic prostate cancer that's spread outside the prostate. They come to see me, they're very nervous, they're very scared, they've looked online and they're hearing that I can't cure that cancer, and it's a super vulnerable time for them. And what I try to tell my patients is that I can't cure it. I'll always be honest, but I can treat it really well for a really long time. And a lot of our treatments in prostate cancer are very tolerable, meaning I have patients who come to see me with metastatic prostate cancer once every 3 months. They come in, they get their PSA drawn. We have an awesome visit talking about their grandkids and how golf went, the last couple months. And they're living a very normal life on treatment, and they're maintaining their quality of life while they get treatment. I think they don't always expect that when they're coming to see me, and so I think once they're living it and they see it happening, that, oh my goodness, my PSA is 0 and I am doing okay. It's wonderful to see that, and it's wonderful to be a part of that with them. And of course there's outliers, that's not everybody, but that's a lot of my patients.
Of course. Oh my God, that's such a good message. Thank you so much, Dr. Brown, for all your explanation and this important information. That was Dr. Brown, medical oncologist from Emory Hospital here in Atlanta. And now we'll leave you with this last message from Jeff Oliver, how he survived prostate cancer and his call for that PSA test that saved his life.
You have to be your own advocate, and you have to make sure you do the research, and you have to be 100% happy with the decision that you make. Do not let the doctors make the decision for you. Every man should get checked out. If you have any history, you just need to tell your kids so they can follow up on the disease. And it's a very treatable disease. So, yes.